Hi, we're here with Dr. Bilamovitz, who presented on botulinum toxin injections for the treatment of spasmodic dysphonia. And this is the follow-up webinar with him to respond to the questions that we did not have time to answer live because of time limitations. So thank you, Dr. B, for being here, and we'll jump right in. So
Great.
first, we've got some questions just around kind of terminology. How would you describe medical management in general for voice conditions?
So medical management can start at the level of the primary care. And so certainly anything that is associated with hoarseness, very common with a viral event, viral upper respiratory tract infection, with coughing, and patients get a hoarseness of the voice. And then after that, if patients have persistent hoarseness, that persists for beyond 6 weeks, it's usually recommended that they be referred to a specialist. The patient then would be seen by an otolaryngologist in the office. And again, the majority of people that are in practice in the United States are general otolaryngologists. So most patients will get some type of a flexible examination in the office with fairly basic equipment, and be told that they have a problem or that they have a condition that will likely resolve or need some kind of medical management. And if the patient has something that is very sophisticated or they're unsure of the diagnosis, then those patients oftentimes get referred to someone like myself, who is a laryngologist, and would then use more sophisticated equipment and certainly have a bit more experience evaluating patients with voice disorders to come up with a diagnosis and treatment plan.
Wonderful. Thank you so much. Another terminology question. What's the difference between vocal cords and vocal folds?
So they're the same. In American English, vocal cord is spelled C-O-R-D. In British English, vocal cord is spelled C-H-O-R-D. And then the vocal fold is the same. The reason most medical people like to use the word vocal fold is that it's not really a cord or a thin band like you would say on a guitar, but instead it is a fold of tissue. The tissue is very three-dimensional, has multiple layers. But do know, though, that our Center for Medicare and Medicaid Services, which provides all the diagnostic codes, uses the word vocal cord. So oftentimes patients will see in reports fold from the physician, especially a laryngologist, whereas they may see cord in their diagnosis. So again, it's older terminology versus newer terminology, but it does refer to the same thing.
Perfect. Thank you. When a person is having botulinum toxin injections, do you recommend voice therapy so they can learn how to talk again? Do we need to relearn how to use our vocal cords after treatment?
So most of the time, patients will reset back into their non-spasmodic type of voice condition, and they can do very, very well without voice therapy. There's been some studies that have demonstrated that voice therapy can help the patient assist in prolongation of the voice, of the good voice after a Botox injection. But as far as the primary de novo need to relearn through an education process or a training process, the answer is generally no.
So there are different ways to inject Botox. And this question regards, why do you think some doctors don't use an EMG machine?
They don't have an EMG machine. They don't know how to use an EMG machine, or they don't know how to interpret the EMG signal. Would all be very good reasons to not use that. If you're performing a transoral injection under direct vision, um, or a external injection where you use a scope to confirm location based upon physical anatomy, then the EMG would be redundant. And so in those cases, an EMG is typically not used. EMG is used by most laryngologists who are performing injections through the neck to help confirm not only muscle placement, but also sites of the muscle that are very active, because oftentimes previous injection sites are relatively quiet despite the patients having a return of symptoms after the Botox injection.
Great, thank you. When you use smaller doses of Botox, like less than one unit, do you dilute it more than other doses in order to have sufficient liquid to inject?
That's absolutely true. So for myself, I like to inject by volume between zero point 0.1 and no more than 0.3 cc's in each vocal cord. If you do injections that are at a higher level, um, you'll start having an augmentation effect, and the patient will leave the office hoarse. So again, there's no reason to have the patient endure that over injection effect. So zero point 0.3 cc's is my max dose. Less than 0.1 cc is starting to get very, very dicey as far as actual delivery of adequate volume, being certain that your delivered volume into the affected muscle. And so for that reason, I would never inject less than 0.1 cc. So if someone's getting a, a 1 unit injection, that's going to be typically diluted at around 1 unit per zero point 0.1 cc. If someone's going to get 0.25 cc's, that will get diluted down to 0.25 units per zero point 0.1 cc. If someone's getting 10 units, then I'll typically inject that at 5 units per zero point 0.1 cc, and those patients would then be getting 0.2 cc's.
And do you typically inject bilaterally or unilaterally?
About 2/3 of the patients that I inject receive bilateral injections.
Great. Um, is it typical for Botox injections to be extremely painful?
It's not typical for them to be extremely painful, but some patients are more sensitive than others. Certainly, patients that tighten their muscles during an injection, they kind of squeeze their larynx, those patients are going to have a more difficult injection, and it's going to be harder to penetrate the muscle. It's also going to be more painful. So just like if you're getting a intramuscular vaccination, everybody will say, please relax your arm, relax your arm. So if you were to be holding a weight and doing, say, a fly where you lift your arm out to the side and then they injected the deltoid muscle, that's going to be a lot more painful than if your arm is by your side. So relaxing the muscle is very important to minimize pain. Interestingly, for a mystery I've never quite understood, most patients find the right side to be more painful than the left.
Oh, that is interesting. Maybe it's something with the anatomy or
I, I don't know. I don't know. I mean, the nerve takes a different route on the right side compared to the left. But definitely the right-sided injections are more uncomfortable for the patient when they do a bilateral injection.
interesting. Another question regarding injections. I have tremendous anxiety about injections. Is that common and do you have anything you could recommend?
Some people have needlephobia. They really, really do. I was operating on someone yesterday, different condition, and it's a healthy 30-year-old thin person who's had very little interaction with the healthcare other than routine checkups. And she was having a panic attack about getting an IV started. Some people are very, very fearful of needles. The majority of people aren't. I know that I, as a child, I grew up in an era where people used to get benzathine penicillin injected into their gluteus maximus muscle, and that's like motor oil, and it's like 3 cc's. I mean, it's very viscous. It's a large volume, and you generally, I remember going out of the office limping. It's very painful. Whereas getting a flu shot is, 0.5 cc's with a very small needle, and typically is not very painful at all. But there are patients that do have really bad needle phobias. It don't know exactly what is best done for that. I don't have any patients that take an anxiolytic medication. That's something that could be done, like Ativan. But it's that's a problem that some patients have.
Okay, thank you. With choking on fluids after injections, is it okay to use Thicket or something to thicken fluids to avoid choking?
Definitely, that's certainly going to be beneficial. The hardest thing that we do when we swallow is swallowing liquids, and it's not because of the reduction of viscosity. It's just because it is due to the reduction of viscosity, and it's because that has to be separated from the airway, and our ability to manage that by drinking quickly, especially with our chin up into drinking the bottom of a cup that has ice in it. You have to raise your chin to get the last of that liquid out of the bottom. That's a very, very demanding task for our airway in our throat to be able to separate the liquid and keep it out of our airway. So anytime we do an injection into the larynx, patients will have a tendency to choke on liquids. But again, it typically lasts no more than about 4 days. During that time period, I've always told patients be careful, keep your chin down, don't gulp. And if you do have problems, drink with a straw. I've never had to have a patient use Thicket for that particular type of problem. Patients with recurrent aspiration, with chronic dysphagia, yes, that's for certain a good technique. But Thicket is something that's generally not required after Botox.
Okay, thank you. Another question. 1 month ago, I received 2.5 in one cord and 3.0 in the other. No side effects this time, but no results either. No improvement at all. Why does this happen? I have adductor spasmodic dysphonia.
So if you look at all comers for Botox injections, the the non-responsive rate is around 8%, which is a which is higher than anybody would like, any patient would like, I would like, but it happens. And part of the reason why this happens is that the medication at times is injected next to a blood vessel that we can't perceive with our needle, and the blood and the medication ends up going into your bloodstream and is diluted out into your body and has no clinical effect. Another reason is just a geographic miss. A third reason is a patient is having a difficult time with the injection and they're coughing, and we're not really 100% certain if the medication got delivered into the muscle or if instead it ended up somewhere in their airway. And some patients will have a sensation that they're tasting the Botox or they feel the Botox going into their throat. But in general, that condition doesn't really happen much at all. And a lot of those patients will actually have a good effect despite having that sensation. But again, so I'd say geographic misses or hitting it next to the blood vessels are the two most common reasons for people to not have an effect.
Okay, and you kind of touched on this, but another question we had was, can Botox migrate into other parts of the body?
Yeah, so the medication is injected typically into the muscle that's within the vocal cord using either an anatomical approach or EMG guidance. That Botox can migrate into surrounding muscles, but within the vocal cord, there's not many muscles that it can get into. Um, if you're injecting it into other locations, like I do a lot of cricopharyngeus muscle Botox injection. So this is the muscle that borders between the esophagus and the pharynx. That's just kind of like a set of muscles from one to the next to the next, and there's no real muscle covering that would separate or compartmentalize the Botox. So you try to keep the muscle directly into the cricopharyngeus without it spreading into the esophagus or the pharynx. But we certainly wouldn't be concerned of injecting the cricopharyngeus and having the medication somehow land in your eyelid muscles or in your hand or something like that. So anything that goes through the bloodstream is going to be diluted out because of the very, very small number of units that are injected in patients with spasmodic dysphonia.
Now, this is more regarding insurance. One insurance company didn't approve the brand name Botox, but it did approve Dysport and Xeomin. Can you speak to this?
I cannot. You have to call your insurance provider. It's a corporate decision. It's a barrier to access of healthcare. And I'm in the DC area, so here in the we majority of patients are from the district, Maryland or Virginia, some from Pennsylvania, and then some fly-in business, uh, mostly from Florida. And the majority of patients have no problems getting regular botulinum toxin type A made by Allergan, approved for their injection.
And I will just add too that Dysphonia International does work for advocacy on these kind of issues. And so if you are having trouble with approval, please contact our organization. Our website is dysphonia.org. Unfortunately, usually people are the exception, not the rule, but we do try to help with approval processes. So thank you. I know it's challenging from the physician side too with the office trying to get approval. Um, so what about false vocal cords, injections into the false vocal cords using fiber optic visualization?
Yeah, there's some laryngologists out there that have a strong feeling that this is a very effective treatment, especially for someone with muscle tension dysphonia, where you have a high degree of false vocal cord or ventricular vocal fold um, hyperfunction that's kind of persistent throughout the voicing tasks. And so for those patients, there's been studies that have demonstrated significant benefit. I will say, though, that if you anatomically look at the ventricular folds, there's not a lot of muscle fibers in there. And but obviously there is some, and so you are treating those muscles selectively, and in those patients, that's been beneficial.
Great. And kind of sticking with other muscles and other treatments, do you have any experience in respiratory dystonia with Botox injections in either the true or the false vocal cords?
I do, yeah. So patients with paradoxical vocal fold motion is going to be the patients that are mostly patients you're going to consider this treatment. So these are patients that have the movement of the vocal cords into the airway while they breathe in, and then they open when they breathe out, which is absolutely opposite of the way the system works. And in some patients, that can be beneficial where you um, relax the muscles and the dystonic type of activity dissipates and resolves. It's not a chronic condition in the majority of patients, it's an intermittent process. There's also voice therapy techniques that can also significantly benefit those patients with this problem. And so, what was done in voice therapy is the patient is taught how to relax their breathing when they feel like their airway is cutting off, and it seems to be effective. There's also medical management for that as well, but Botox can be a benefit. I don't typically use that as first line. I I try to do non-invasive therapy first, including medical management as well as voice therapy.
Great, thank you. And what about in tremor? Do you use Botox to treat vocal tremor?
So the patients that have an adducting tremor are patients where their voice cuts off significantly during the utterance, as opposed to just a wavering of the voice. Those patients can get benefit with Botox. It's not as complete of a treatment response as the patients with adductor spasmodic dysphonia, but it can be used. There have been some studies that demonstrate treating some of the muscles outside the larynx with vocal tremor can also be of benefit. So see, these are some of the strap muscles or the linear muscles that run in the front of the larynx.
Great. Does long-term Botox use require a higher dose as one ages?
So as we age, in a good number of people, the muscle volume diminishes over time, and that can occur in the larynx. In those patients, you oftentimes decrease doses because you have less of an overall bulk of muscle activity to treat. If you look at all comers for Botox and you look at them over a 5 year period of time, so now we've got an average age range, say, of 40 years old, and over a 5 year period of time between 40 and 45, the overall dose effect tends to diminish by a little bit. And the reason for that is some of the persistent effects of Botox at the neuromuscular level. And again, a single Botox injection can have a neuromuscular effect that lasts 2 up to 4 years. And so that would be a cumulative activity of kind of chronic denervation, such that, again, you've diminished the overall bulk of muscle that you're having to treat, and thus you decrease the dose.
And kind of along the same lines, is there a risk with repeated injections over time that scar tissue could develop and hinder the effects or the results?
Yeah, no, that's unfortunately not been in a problem in any patient I've ever managed. I've got patients that I've treated over 100 times. Um, Again, if you look at someone that has diabetes who injects typically the muscle of their abdomen. Granted, it's a fairly large area. I mean, they do injections once a day, twice a day for their entire lives. So that's over 700 injections a year times, say, 50 years. That's a lot of injections. And so, fortunately, scar tissue with needle placement, these needles are so small that the amount of damage that occurs is minimal. And also, the medication itself does not cause any type of fibrosis or an inflammatory response that would lead to scar.
And we had quite a few questions regarding immunity to Botox, from anywhere from treating it for 8 years to 14 or 15 years, where they had consistent results, but then it stopped working. And the question was, did they become immune?
So that it is a very, very rare condition to become immune to Botox for spasmodic dysphonia. It does happen in large muscle dystonia, like limb dystonia, where patients are getting 3 to 5 bottles of Botox injected at a time. So 300, 500, 800 units of Botox with an injection. And if you do that 3 times a year for a period of 20 years, that's a lot of Botox that your immune system is seeing, and you can mount an immune response and develop immunity. For patients with spasmodic dysphonia affecting the larynx, the injection doses are typically on average about 2 units total, 2.5 units total. And that is such a small, small amount that the risk of developing immunity is very rare. I've only met one patient ever, and that was when we were looking for people like this. And that was a study that I did out of the NIH. We identified one person who was way outside our area, lived in the West, and we were able to diagnose this. So again, it can be diagnosed by by a immunological analysis of the blood to determine if there are antibodies to Botox that are circulating in the patient's bloodstream.
And one person had said regarding the immunity, the neurologist suggested an injection into my forehead as well, and it had no effect either. And I gave up, but would you suggest a larger dose?
Usually that is kind of become the gold standard. I'm not a board certified neurologist, but from talking to my movement disorders friends, when I've had patients where I was concerned about immunity, that's generally been the recommendation. Is they said that the ability to detect antibodies is pretty difficult without like having clinical botulism like you would get with food poisoning. So they generally do a functional Botox injection, and again, they typically will use. Historically, what they used to use is the muscle of the base of the thumb, and that's important for being able to grasp. So, like um, picking up a mug, that's required. You have to use this muscle here at the base of the thumb, and so they used to inject that, and then they would check for muscle strength in a couple weeks to determine if there had been a clinical effect. But most people have transitioned to injecting muscles of the forehead, which cosmetically is something that's done on a regular basis to look for an effect.
And do you think trying a different product like Xeomin would work or have a different effect if somebody's not getting a response to Botox?
Yeah, absolutely. I mean, you're trying to use a different subtype of Botox, and the immunity tends to be specific to the subtype of Botox that has been exposed.
Okay. And you kind of touched on this with limb dystonia, but we had two questions, one regarding Botox immunity for people who are receiving it for migraines, and then also another person who's receiving it with for cervical dystonia. And would that interfere with injections or immunity for dysphonia?
Well, if you developed an immunity because of cervical dystonia, yeah, it's going to have, if it's a generalized immune system immunity to Botox, that's going to adversely affect your ability to respond to the larynx. But again, even there, I think it's still a fairly uncommon clinical condition. Cervical dystonia is a very painful illness. So not only does it cause a change in neck position, but it's very, very uncomfortable. And so that's the reason patients are typically motivated to be treated for this. And if they respond, then they should go ahead and do the treatment, obviously. Um, and there was a second part of the question.
It was regarding migraines. So, do you think having injections of Botox for other parts of the body, whether it's migraines or cervical, could increase the possibility of becoming immune?
It could, but again, like I said, these are really rare occurrences to develop immunity to Botox. So I wouldn't have that in the front of my mind in making decisions as to proceed with Botox injections or not.
Okay. And if immunity is rare, what are the other thoughts or candidates for reason for reduced effect?
Some patients, especially those that have tremor, so they may have adductor spasmodic dysphonia with tremor. Over time, the tremor component in those patients can worsen, especially if it's related to essential tremor. And so in those patients, Botox is not as effective in treating the tremor as it is in treating the actual spasmodic dysphonia, or the spastic activity within the muscles of the larynx. And so for those patients, Botox can become less effective over time. There's also another issue I think that happens, and that is in patients that get older, their ability to tolerate Botox becomes less because of muscle weakness. And so that is another reason why patients, as they get older, can sometimes have a reduction in the effectiveness of Botox. But again, this is also an uncommon condition, and I personally have only run into this a couple of times.
Okay, thank you. And another person wrote that they felt that antibiotics eliminated the effect of their botulinum toxin injection after 2 days of taking it. Do you think there could be a connection between antibiotics and the effectiveness of Botox?
There's a connection between an infection and the effectiveness of Botox. So, in general, if someone has an active infection, we're talking either bacterial or viral, I typically do not like to have the patient receive their Botox injections while they're still having a need for an antibiotic, or within the first 1 week of having symptom onset with an upper respiratory tract infection. So patient calls up, says, hey, I woke up this morning. I'm scheduled for my Botox injection at 11. I've got a sore throat. My nose is stuffy. I think I'm coming down with a cold. My recommendation would be to wait until your upper respiratory tract infection symptoms have resolved to initiate that Botox injection. Because if you do it at the same time, while there's no harm in doing the injection, the take rate's about 50%.
Oh, interesting. That's good to know, and something that we should probably include on our website for advice on injections. I don't think that's really been talked about a lot, to be honest. So thank you for that.
Oh, yeah, you're welcome.
So another question, and this is kind of shifting gears a little about connection to other diagnosis. Can you talk a little bit about the difference between spasmodic dysphonia and muscle tension dysphonia?
So I think we talked about this earlier in the webinar, and I think it was a question. So I remember talking about it. But what the difference is that muscle tension dysphonia is a persistent tightness of the voice. So there's an overactivation of the laryngeal muscles throughout the entire speech pattern. Whereas with spasmodic dysphonia, there's episodic overactivation of the muscles. So patients with muscle tension dysphonia, so again, one of the classic sentences is we mow our lawn all year. So that's intermittent spasticity of the vocal fold, as opposed to the person with muscle tension dysphonia that's going to sound, we mow our lawn all year. So it's just consistently, persistently overactive and tight.
Okay. And do you see any correlation between adductor SD and dysphagia?
In general, no. In general, they're separate problems.
Okay. And another person had been diagnosed with adductor spasmodic dysphonia, essential tremor, and Charcot, and I'm not going to say this right, Charcot-Marie-Tooth syndrome. And she feels that the CMT is the primary cause for the voice issue and had a very bad reaction to Botox, and would like to pursue other avenues. Do you think surgery might be beneficial? I know that's a difficult one to answer without seeing the patient.
Yeah, I mean, I think that's really very specific information and is would need to be tailor-made for that particular individual, because that's a very, very rare medical condition to have, Marie Charcot-Tooth illness, and to then add on to that spasmodic dysphonia and have some general recommendations, I think would is not appropriate.
Thank you. And have you had many patients that have experienced stridor after injections?
I have never had a patient develop stridor after an injection.
Okay.
For
And
a Botox, of Botox. Yeah.
yes, yes.
Yes,
Okay.
I'm very happy with that.
And then another person said that she had tried gabapentin and she noticed that her voice improved. The dysphonia symptoms decreased dramatically.
Yeah, so gabapentin is the medication, and it is a neuroactive medication that affects the GABA system. So GABA is one of the neurotransmitters that's in the brain, primarily in the brainstem, and it's also a part of the pain system as well. So GABAergic, increasing the GABA levels of the receptors in patients with neurological illnesses can be effective. And so, if they had a treatment response to gabapentin for their spasmodic dysphonia, that's wonderful. And I'm glad they had that. There are no studies that would demonstrate the efficacy of that medication generally for this illness. So in general, it's not recommended as a treatment option for patients with spasmodic dysphonia.
Okay. And can you have shortness of breath if you have spasmodic dysphonia?
In general, no. We talked about paradoxical vocal fold motion. Those patients do have shortness of breath. Um, Patients that have incomplete vocal cord closure due to vocal cord weakness definitively have shortness of breath, especially with talking. But patients that have spasmodic dysphonia, if they're really, really, really tight and they're having a hard time, I think if you remember from my talk, I had two EMG channels. One showed a normal person. They were saying one of our classic sentences, it took the person 7 seconds, and the other person, it took them 1.8 seconds. So the one with 7 seconds has all the spastic activity. Some of those patients do have to take breaths between their utterances if they're very, very tight. And in those patients, they can feel short of breath when they talk. But in general, it's something that doesn't happen unless you have a very severe case of spasmodic dysphonia.
Okay, thank you. And then we had two questions regarding surgery. And so one is there an option for abductor AB spasmodic dysphonia for a surgical procedure?
Yes, I mean there are treatment options. Basically, it's some procedure to help reduce the bulk of muscle of the posterior cricoarytenoid muscle. Again, this has to be someone who has a spastic activity of the PCA muscle. There's also it's there are a couple of different techniques that are done to help reduce the bulk of the muscle. And again, I've done a couple of those. In general, that's not necessary. I also mentioned earlier that there is a group of patients that have a persistent difficulty with closure of their larynx throughout the entire voicing tasks. Those patients look more like you see in patients with severe aging, but they're not old, but they don't have aging, they're not old. And in those patients, augmentation procedures of the front of the larynx can be beneficial, but that only represents about 20% or so of patients with abductor spasmodic dysphonia.
Okay, and for AD, adductor with tremor, they're asking, I get Botox roughly every 3 months, which manages my symptoms pretty well after a period of breathiness. Would I be a good candidate for the SLAD R surgery? And again, I realize that this is probably an individual question that needs
No,
diagnosis.
no. I think this is a good general question. I think uh, so. The ideal candidate who is considering the selective laryngeal denervation, reinnervation surgery is someone who has pure adductor spasmodic dysphonia without tremor. So the procedure is meant to correct that over tightening of the larynx. The modulation piece that's associated with the tremor is oftentimes not affected by the surgical procedure. So that so again, that's not the ideal candidate. That's less than the ideal candidate. It can be done though, but it's just the effect is not quite as beneficial as it is with the Botox injection. As I'm sorry, as it is in someone who does not have the tremor component.
Okay. And after being intubated for surgery, can muscle tension dysphonia occur? And can it be a result to an injury of the voice box?
That one I've not ever seen before.
Okay. How about with vocal cord paralysis or paresis after surgery?
I have seen patients who had a history of vocal cord paralysis and their larynx recovers, and then they go on to develop spasmodic dysphonia. So do think that that is a mechanism. It's a very, very rare mechanism, but again, it kind of makes sense because what happens is that the neural system is injured and the neural system recovers. There's actually a good amount of plasticity that occurs, and nerve fibers will continue to regrow into their target muscles over a period of 2 to 4 years. And so in some of those patients, they'll go on to develop over tightness of the muscles and develop spastic activity, which is consistent with spasmodic dysphonia.
Okay, and thank you so much for all of these answers. And we've got one last question. Will this voice disorder ever go away?
Unfortunately, the only patients that I've ever seen that the disorder goes away have been misdiagnoses.
Okay, thank you.
You're welcome.
Again, we appreciate all your time and your knowledge and your experience, and really, most importantly, your dedication to the voice community and to our organization. So thank you so much, Dr. B. We really appreciate it.
You're welcome. You guys have a happy holiday.